welcome everyone to another insightful episode of MedSynapse podcast series, where we connect with healthcare experts to decode complex clinical challenges and emerging practices in medicine. I'm your host, Hetvi Shah, and today we're diving deep in a critical and often life-threatening condition that has gained increased attention post-COVID, which is Acute Respiratory Distress Syndrome, or ARDS. To help us navigate this complex landscape, we have with us an expert in the field, Dr. Rupan Bhadury, a seasoned critical care specialist fellow and anesthesiologist who is currently with Medica Super Specialty Hospital. With an extensive background in intensive care, anesthesiology, and pain management, and a deep passion for evidence-based medicine, Dr. Rupan brings both clinical acumen and clarity to the table. Dr. Rupan, welcome, and we are so thrilled to have you here with us today.
Thank you, MedSynapse, for inviting me and letting me give a talk on ARDS. I'm currently practicing critical care medicine as a DRMB fellow in Medical Super Specialty Hospital. So today I'm going to talk about ARDS.
Yeah. So we're excited to talk about this topic, Doctor. And to begin with, could you walk us through the pathophysiology of ARDS and how our understanding of it has evolved, especially with lessons learned from COVID-19 pandemic?
Okay, so we are having a lot of talk and crosstalks on ARDS since the COVID era. And previously it was kind of difficult to diagnose, and also there are many missed cases in ARDS. So before I start with the pathophysiology, I would like to talk about a case scenario, how we approach to a case of ARDS. So in our setup, 28-year-old male patient, young patient, came with a history of fever for 2 days and was having dyspnea and tachypnea. So he was admitted in the ICU because his respiratory rate was on the higher side. And on examining, his BP was normal and he was having respiratory rate around 30 to 34. His saturation was progressively going down from 100 to 90 to 80. And on auscultation of the chest, there was bilateral coarse crepitation. So chest X-ray, we have done chest X-ray, it shows bilateral consolidation. And it was more on the right side. A throat swab was sent and H1N1 came out to be positive. So it was a case of COVID, but with decreasing saturation, he was admitted to the ICU. So before I come to the conclusion, this is a case of acute hypoxemic respiratory failure. So we need to rule out other causes of hypoxic respiratory failure here. So we did an ABG. The ABG, from the ABG, we can see the PaO2. The PaO2 was on the lower side for this patient. So as we know, we have to see an P-alveolar arterial gradient here to come to a conclusion of ARDS. So we need to rule out pneumonia first, very important. Then a history of COPD has to be ruled out. And there is pulmonary edema also, because heart failure can produce bilateral consolidation of the chest X-ray. And there is underlying pulmonary fibrosis or interstitial lung disease that needs to be ruled out. Asthma, pneumothorax. Bilateral pneumothorax may present as bilateral infiltrates on the chest X-ray, so it's difficult to come to ARDS. And also other rare case causes of bilateral infiltrates that can be diffuse alveolar hemorrhage, granulomatous lung disease, and then bronchiectasis, fat embolism. So we have to do all the investigations like ABG is very important to see the PA arterial alveolar gradient. And then we have to do a complete blood test to look for any chronic disease, underlying diseases. So in this case, we diagnosed it as a case of ARDS because it meets all the criteria of the ARDS. So so what is ARDS? So it is defined as, it was defined by the presence of non-cardiogenic edema and hypoxemia due to direct or indirect lung injury. So in this case, the foci was the H1N1 virus infection. So what happens in an infection or any other cause of producing cytokines and chemokines, it directly involves the lung parenchyma, injures the cells and causes the alveolar damage, resulting in flooding of alveolar walls, breakdown of neutrophils, release of proteases, and further release of interleukins and chemokines, causing further damage to the alveoli, causing flooding and exudation. So the basic pathophysiology divided into 3 phases, that is exudative phase, the proliferative phase, and the fibrotic phase. The exudative phase lasts for around the first 7 days, where there is exudation in the alveoli causing flooding of alveoli with the exudative fluids which prevents any oxygenation of the lung, causing reduction in the oxygen PaO2, and also there is shunting because flooding prevents the exchange of the gaseous exchange inside. So after the exudative phase, there is proliferative phase, which starts exactly 7 to 14 days after the initial phase, which leads to repair of damaged epithelium and restoration of all the barrier functions and proliferation of the fibroblast, followed by the fibrotic phase, where there is recovery, but it may lead to permanent fibrosis of the alveoli. So this is how the pathophysiology and understanding of the ARDS starts. And so further it causes in the exudative phase, it's called the endothelial damage, which also finally causes damage to the type 2 pneumocytes, which acts as a lung surfactant. So the lung surfactant keeps alveoli open. So this is a very important concept in ARDS, where the lung alveoli starts collapsing because there is decreased production of the type 2 cells, causing collapse of alveoli. So recruitment maneuver and all these things comes later on. But with the advent of COVID, there was a difference in the understanding, because there was a paper by Gattitoni which showed during the COVID era, 50% of the patient had normal lung compliance. And there were ideally we go for proning in ARDS patient if this in case of severe ARDS, but in these cases they have seen there was no benefit of proning, and also in some cases there was no benefit of recruitment maneuver also. So he has divided it into two types: the L types and the H type. The L type was the normal compliance or the high compliance with low elastance, and the H type was the opposite one. So in the L type may convert into H type, but for the treatment for H and L were both different. Though this is not practiced nowadays, but during the COVID era it started. Like with L type, we have to give more tidal volume, unlike the H type where PEEP, with emphasis on PEEP is given. So in the L type, the tidal volume was around 8 to 9 ml per kg, which is like quite different from what we do in ARDS management. And the PEEP was around 5 to 10. And the lung volume was also less in L type, because there was less amount of flooding of the alveoli, unlike the H type. So there was no role of conservative fluid management in the L type. So the approach for two cases were different. And also the pathophysiology also, they discovered there could be some kind of microthrombi in the vessels. So for that, DVT prophylaxis was also important in the L type. Though the L type may later on convert into the H type, and we go for the normal management in ARDS cases. So this is it.
I think that was a great overview, doctor. So now, ventilatory management remains central to ARDS care. So could you share how you implement lung protective strategies in your practice, and also which parameters do you monitor most closely to guide your approach?
So lung protective management, before we think of lung protective management, it's very important to treat a patient conservatively without going into ventilator strategy. So first we have to try with HFNO or NRBM mask. So there was a trial called the fluoride trial. They included all the ARDS patients, but they made sure the PaCO2 was less than 45, and the respiratory rate was not very high, and the GCS score was not less than 12. So for these cases, we can start with non-invasive modes of ventilation. So it has been shown HFNO, and these were non-inferior to other modes of non-invasive ventilator. And also in some studies, in the French study, it was shown it has decreased the rate of mortality also. Clinical outcome was better, though there was no difference in the intubation rates for going for NIV, but the clinical outcome, the oxygenation was improved, because if you go for NIV, the best thing about NIV is you don't have to go for sedation. So it does not weaken the diaphragm and all the complications related to intubation. And also the ventilator associated pneumonia is a very important thing that happens around 3 to 5 days after the ARDS sets in. So we have to go for another mode of treatment. So that is avoided. It reduces the afterload. It increases the compliance and oxygenation. So we should always try for giving NIV unless and until the GCS is less than 12 or the respiratory rate is very high, that our hemodynamically instability is started to occur. So we should initially start with an NIV therapy. Although the rate of intubation has not changed using NIV, but the index like RBSI, if it is more than 105, then we have to go for intubation, or the GCS is going down. So we have to start with NIV, and then if it fails, we will go for ventilation. That is, lung protective ventilation is a very important thing here. So what we do is basically we have to start with low tidal volume and high PEEP strategy, because as I said, there's a problem in the recruitability and of the lungs. So some lungs are collapsed, some lungs are open. So the collapsed alveoli causes shunting of blood, and also there is no proper distribution of oxygen. So it's important to give high PEEP and also reduce the tidal volume. But in these cases, we have to keep in mind there is chances of patient CLE. PCLE is a very important thing that can injure the lung because of the constant closing and opening of the lung. So the recruitability is very important. So basically, we measure the predicted body weight of the patient. There's a formula, you can go through that. So, and depending upon that, and keeping the PEEP plateau less than 30, and the respiratory rate has to be optimized, we go for lung protective ventilation, because there were many trials done, like the landmark trial, the ARMA trial, which followed the ARDS net protocol. They showed a mortality benefit of using low tidal volume ventilation. And also high PEEP is important, though there 3 studies were done. That is the alveoli trial, the LOVES trial, and the EXPRESS trial, which showed the oxygenation improved with giving high PEEP, although the mortality, there was no change in mortality benefit. But we normally follow that unless the patient lung compliance improves, and we gradually taper it off.
Yes, I think that is very insightful, Doctor. Now there has been a lot of discussion around corticosteroid used in ARDS. So with opinions evolving over time, so based on your current evidence, when do you consider steroids appropriate, and in which patients especially?
For steroids, there is a lot of studies that has happened. Like for the early phases and the late phases, it has been shown if we give steroid in the first 72 hours of the ARDS injury, they have shown better outcome in the patient, including ventilator-free days, ICU mortality benefits. So in a study, there was a study which was done using methylprednisolone. It started with 2 mg per kg dose of methylprednisolone, then gradually tapered off to 0.5 mg per kg for 6 hourly for 7 days, then 0.5 mg per kg 12 hourly for 7 days. It has shown a good result here, and the clinical outcome was also good, including the ventilator-free days, the mortality benefits, and also the patient recovered. But using steroid in the late phase of ARDS, like after 14 days, there was more harm rather than not giving steroids. So it is important to use steroids when actually are we going for the steroids. So it's very important that we give in the early phase, especially in the first 72 hours, it's very good results. So you can start with methylprednisolone or dexamethasone. Dexamethasone dose is started like 20 mg OD for 5 days, then 10 mg for the next 5 days, and then gradually tapered off. So 20 mg OD dexa is equivalent to 106 mg of methylprednisolone, which is roughly around. So we are starting with methylprednisolone 2 mg per kg. We can also, that is around for 60 kg, it's 120 mg methylpred. And for like dexa, we started with 20 mg, and then gradually to 10 mg OD, and then tapering off. But and also surprisingly, using dexamethasone, it also reduces the infections. So we can have a correlation with community acquired pneumonia, where we give dexamethasone, and it has been like in severe cases associated with septic shock or in severe CAP. So the dexamethasone has a role in reducing the infection rates, also improving mortality, improving in ventilator-free days, and the long-term benefit of the patient. So using dexamethasone or methylprednisolone in the early phase of steroid is very important. So we have to keep this in mind, because steroids have a huge role in benefiting us in ARDS cases.
Yeah, correct. So now, Doctor, when conventional ventilation fails, what's your approach to advanced interventions like prone positioning, neuromuscular blockade, or even ECMO for that matter? So especially in refractory ARDS cases.
Okay. So we initially started with NIV followed by conventional modes of ventilation, and if the conventional mode of ventilation fails, we may go for other modes of ventilation. So there was for proning also, there is a trial, the PROSEVA trial was done, which showed the proning of the patient in certain cases where the PaO2 FiO2 ratio has decreased severely. So severely as in like less than 100, and also there is no hemodynamic instability, and it has shown that proning has improved the benefited ARDS if you are giving it for 16 hours a day. then followed by the change of position. But it involves a lot of people in the ICU. So it is important to have proper staffs, physiotherapists, and somebody who can help you out with the proning process. Because proning, basically what happens if you're like proning the patient, it improves the lung recruitability, because on the dependent side, the lungs usually collapse. So if you're like switching places, the collapsibility reduces while giving proning and improves the oxygenation. But we have to keep in mind, because proning has a lot of other contraindications also, because with ARDS, if it is associated with arrhythmia, or there is any GI ulcers, or any hemodynamic instability is present, or the ICP is raised, or if this is the case of traumatic brain injury with ARDS, because ARDS is also related with TBI. So we have to keep this in mind. So for these cases, proning cannot be done. And now coming to ECMO. So ECMO, there were 2 trials were done for patients with ARDS when the conventional modes of ventilation failed. So what they did, there was a Caesar trial and the Eolure trial. So what happened in Caesar trial, they used patients who have received all the modes of treatment, including the CMV or inhaled nitric oxides, and every other modes that are present, like HFOV. So they included patients who having a Murray score of greater than 3, the pH less than 7.2, respiratory rate more than 33, and in spite of ventilator optimization, the PO2 cannot be reduced. So they included such patients for ECMO. ECMO basically gives rest to the lung, and it prevents any ventilator associated lung injury. So they used ECMO for these patients. What they have found, to study the 60-day mortality. Although the 60-day mortality was not statistically significant in these cases, but it is advisable to go for ECMO if the pH is going down in spite of treatment less than 7.2, respiratory rate is high, the plateau pressure is high, in spite of optimization of ventilator treatment. So they went for ECMO. So it's beneficial to go for ECMO in such cases. And also there was another trial, the Eolure trial. The selection criteria for the patients for them with ARDS was CMV with all the modes of treatment. In spite of that, the PF ratio was less than 50 for 3 hours, or PF ratio was less than 100 for more than 6 hours. So they went for this mode of treatment, although they did not show much statistical benefit, but these are certain criteria for which we can switch to ECMO. So other modes of treatment like inhaled nitric oxides in lows of 5 to 30, they have shown benefit, though transient, because the half-life is very less. So we have to optimize and give for 30 minutes, and then again it basically prevents the shunting because it opens up the vessels, because it prevents pulmonary vasodilatation, and prevents a right heart failure associated with ARDS. So we can go for inhaled nitric oxide also. Other modes of treatment like high frequency oscillating ventilator can be used, which can also be used in spontaneous modes of ventilation. So in such modalities, there is the change of volume between the inspiration and expiration, and the high mean airway pressure causes the alveoli to open up constantly. So there is no factor of constant opening and closing of the alveoli, which may lead to CE or any kind of other kind of things. And VAP is also prevented. So these are the other modes of ventilator that we use, like steroids, proning, and changing to ECMO, keeping the patient in the ECMO. So
I think those strategies are game changers all the time. But now, doctor, finally, how can multidisciplinary teams collaborate better to improve outcomes in ARDS?
Okay, so now we need to get to the history of ARDS, how it started. Like, it was initially proposed by Moore et al. They included in ARDS, they included the hypoxemia, that is the PF ratio, the PaO2, the chest radiographic features, the PEEP, and the lower respiratory compliance. So followed by that, there was a changes by the American European Consensus Conference on ARDS, which involved the timing of the onset, oxygenation, there's any absence of cardiac failure, and the PaO2 FiO2 ratio. Then it was again evolved with the Berlin definition, where they said with the AECC there was no emphasis given on PEEP, because it was shown when the PEEP was increased, there was gradual improvement in the PF ratio. So the Berlin definition included the PEEP in their criteria, And also with HFNO more than 30 liter per minute, they have considered to be a certain amount of PEEP. So, and it was also important to identify the disease within 1 week of the injury. So the Berlin definition included this criteria within 1 week, and origin of edema has to be noted. That is very important because pulmonary capillary wedge pressure is oscillatory and it may be more or less, and there may be any underlying lung disease also. So nowadays these PA catheters are not used. We are more on tissue Doppler and echo monitoring to rule out any heart failure. And with the advent of the global definition in the 2024, they have made certain changes with the Berlin criteria also. So now they are saying unlike the Berlin, which said there's an acute injury within the past 1 week, global definition says it may be acute and chronic because there may be an underlying lung disease or a heart failure. So an acute case over the chronic can occur. So these are the certain things that has been included in the definition of ARDS. And also chest infiltrates they have said we can also use ultrasound, because we commonly use a lot of ultrasound in the ICU for to rule out any heart failure like pleural effusion or any nodule. That also could present as bilateral infiltrates also. So the origin of edema, these are very important. So multidisciplinary approach for a case of ARDS, which might start in the ward and we are not able to judge it properly, and then sending the patient to the ICU. It's very important to keep an eye on that. So a team of critical care physicians, medicine, pulmonology, therapy, physiotherapists, they all need to get involved here. And the primary consultant under whose the patient may be admitted. So for this case, my case, it was a case of H1N1 which presented with ARDS, because maybe it was maybe it could be missed out by other physicians. The four things that we need to keep in mind for ARDS. So involving the other multidisciplinary approach is very important in cases of ARDS.
Yeah, so that is really valuable, and I think collaboration, as you also mentioned, is really important. So, Doctor, as we wrap up today's session, thank you so much for those valuable insights on ARDS. And thank you for sharing those insights with us as well. And to our audience, thank you for tuning in. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay curious and stay informed.